So we are here today to discuss early detection and prevention of cancer, two extraordinarily important topics. There's been a lot of attention in the recent cancer world about immuno-oncology preferentially hitting, in some situations, hypermutant tumors. But I think in almost all other situations, one can think about early detection and preferably prevention of cancers, but early detection at a point where they are biologically simpler and clinically more contained is a good type of thing to aim for. In general, early detection and prevention gets a little less attention in the sense that it's not as sexy as some new therapy that melts away cancers and you can see the pre and the post. But when one thinks about early detection and prevention, the potential cost savings, albeit hard to estimate accurately, the potential cost savings are really staggering to think about, not only in cost financially, but in cost of human suffering. When one starts to talk about early detection, the conversation pretty quickly goes to two areas, one being technology development, and the other being increasing biological understanding. Similarly, when you start to talk about prevention, about either modulating or removing risk factors for cancer, or about detecting them at a stage where they are not yet cancers, again, the conversation pretty quickly turns to aspects of new technologies and of understanding in a deeper way the biology underlying these lesions. So we're going to get at both of those issues as we go through the discussion today, and I'm very thankful to the organizers for putting together such a wonderful panel to address these questions. And I'll ask the panelists to take a moment just to introduce themselves. Andy?
I'm Andrew Chan. I am a gastroenterologist at Mass General Hospital. On a clinical basis, thus, I spend a lot of time in the field of cancer prevention. A lot of what we do in gastroenterology is cancer prevention, specifically digestive disease cancers. The other hat I wear is as chief of the Clinical and Translational Epidemiology Unit at MGH, which is a research unit which is dedicated to really developing epidemiology and epidemiological methods to help us understand how we can address clinical questions. And one of the areas that epidemiology is particularly well poised to help in managing is questions about cancer prevention, because we really need to kind of understand on a global basis what it is about what causes disease and sort of how disease occurs in a population so we can better understand how to prevent it.
Bill?
Yeah, thanks, David, and thanks for having us. My name is Bill Hite, and I am the Global Head of Research and Development at Janssen, which is the pharmaceutical sector of Johnson & Johnson.
Thanks. Krishna?
I'm the CEO for a set of growth businesses at Philips. I particularly look after two areas. One is integrated oncology diagnostics that includes everything from computational imaging and pathology to integrating it with molecular pathology. And the other business I look after is in neuro and cognitive health, everything from neuromapping and optogenetics to cognitive behavioral therapy.
Thanks. And Max?
My name is Massimo Loda, or Max Loda. I'm a pathologist, like David, at Brigham and Women's Hospital and Dana-Farber Cancer Institute. I'm interested in prostate cancer and specifically metabolic alterations in prostate cancer and how to target metabolism in this disease. I also collaborate a lot with epidemiologists at the Harvard School of Public Health, developing biomarkers that are predictive, prognostic in this disease as well.
So the panel is flanked by two pathologists. You can't find a better setup. So we'll begin. There's so much to discuss in early diagnosis and prevention, but as I said, a lot of it revolves around technology development. And so we thought an interesting initial question to ask would be to think about some examples of new technology and their clinical significance, one of which we had bandied about was liquid biopsy types of approaches. But Bill, do you want to take an initial stab on the new technologies coming down?
Sure. So one that we've had on the market for some period of time are circulating tumor cells, the Veridex cell search instrument. But we've learned that it's just not sensitive or robust enough to really pick up earlier forms of cancer. So we've been actually very privileged to be collaborating with Daniel Haber and his colleagues at the MGH to develop the next generation, which we have reason to suspect will dramatically increase the sensitivity of the technology in terms of being able to pick up not just early tumors, but the earliest tumors and have some idea from where they are coming. So that's one area that I know something about, and we remain extremely excited about the potential for this kind of liquid biopsy, if you will, but now moving it, by making it far more sensitive, moving it to an earlier stage of disease.
Max, any ones that jump out to you?
Well, we've been interested for a while in, as I was alluding to before, in metabolic profiling of tumors, and we are, in particular in prostate cancer, we want to distinguish between aggressive versus indolent tumors. And a lot of people have been looking at metabolic profiling that reflect either indolent and aggressive prostate cancer. And since these profiles can be applied to tissues, but also to serum, the development of profiles that might help us in distinguishing indolent from aggressive prostate cancer, but also in other cancers, is very much at the forefront of our interest, and the technology is developing very rapidly towards that. So that would be another area of very intense scrutiny on our part.
You know, there's one other that's really also exciting, also from Boston, interestingly enough, where Avi Spear at BU has been looking at biopsies from patients undergoing bronchoscopy for COPD, and he came up with a signature that placed the risk for having cancer in the field defect, in the so-called field cancerization. That's kind of an aggressive approach, but he's now shown, he has preliminary data, reasonably good data, that you can find the same abnormalities in nasal swabs. So it becomes a much more practical way at assessing the risk of someone who's highly susceptible, a heavy smoker, for example.
Krishna, anything to add from your point of view?
Well, the area of research which is a little further out compared to some of these technologies is really the area of particle imaging and the role that it can actually play in potentially spotting tumors early and also transmitting a lot of information about the tumor much further out. However, I don't see it as a viable technology in the market in the next 10 years, maybe a little longer than that, but certainly a promising technology.
So one of the themes that comes out even from the early discussion is you're seeing emphasis on detection systems. What are the best places to pick up material that can be done, that can be analyzed, whether it's through imaging or through novel ways of doing either individual cells or cell-free DNA or exosomes. And then once you have that methodology, what are the best analytics that go along with that detection methodology? And that's going to come out in multiple places, I think, in our discussions, because there's advances going on in both of those sets of areas. So maybe we can go on now and talk about some of the areas that are really changing the way we do diagnostics and think about how those have become or are becoming clinically useful, as well as some of the barriers that we're facing. And for us in pathology, probably the biggest we're hitting in diagnostic laboratory medicine in terms of transformative technologies that have already been brought into the clinic is next generation sequencing, NGS, because it's really changing almost everything that we do in the molecular diagnostic sphere. And I know, Max, your department has a big experience with this. Do you want to start the discussion about NGS?
Yes, so that has really been transformative in the last few years in terms of both diagnostic and prognostic implications in human tumors. The NGS has, as everybody already knows, the technology has improved so much that the costs have gone down and the depth of sequencing has increased to such a level that we can detect alterations in very small tissue specimens, as well as in circulating tumor cells and free plasma DNA. That has changed dramatically how we diagnose and prognosticate tumors. I think that will have an impact even in the alterations that we could find in normal tissue, for example, in biopsies from patients that are retrospective and have developed cancer over time, and try to find alterations that are early enough in normal tissue that are predictive for cancer development in the future. So that's one of the uses. The other is actually to apply this to early cancers and try and prevent them from in the early stages rather than treat them in the late stages of the disease. As
you said, the breadth and depth of what you can do with NGS is really transformative, and as I said, I think it'll replace a lot of what we do in molecular diagnostics. The hurdles that we're facing right now are largely practical implementation ones, and they relate to reimbursements and pre-approvals for getting these tests done on behalf of patients. And these are quite thorny issues that we're facing now, and both in the local systems, but clearly all around the country. The technology is there, but using it in a practical sense has a bunch of pretty big hurdles still to go through.
David, one of the things that has really struck me over the last several years as next-gen sequencing has become so much more available is that many of our colleagues in the field of cancer research have done the following. They take an original tumor at the time of diagnosis, sequence it, and then at first relapse, sequence it again, and they say, wow, this is fantastically interesting. There are changes. It might be more interesting if there weren't changes. And then after treatment, in a relapse, they sequence them again. And they get more and more excited about this because as the tumor develops and there's more genomic instability, there are more interesting changes. And I've been pushing very hard, at least with our own group and others, to say, well, why don't we apply these same technologies to the very earliest, even pre-malignant conditions, so we have some idea what's going on, so we in the pharmaceutical industry will have targets to aim at. And I'm really hoping that at some point we'll step back from going all the way to the most end-stage patients who perhaps will do better with immuno-oncology, I don't know. But if I were a betting person, I'd bet on getting to the earliest and maybe even pre-malignant conditions.
Yeah, to that point, just to bridge off of that, I think a lot of the focus on NGS has been on the tumor, and deservedly so. A lot of advances there have made profound differences in terms of therapy, but I think there is really the other side of NGS, which I think is a little bit less, has received a little less attention in the field of prevention, is NGS as it applies to early lesions, such as pre-malignant lesions. I think there's an increasing focus on trying to use NGS technology to understand what are some of the early molecular changes in some preneoplastic lesions, i.e., for example, colon polyps. Can we actually identify, are there molecular subtypes of colon polyps that are more likely to progress into cancer? But then NGS also could be very easily applied to a patient's germline, understanding are there germline predisposing polymorphisms that could really predict whether someone's going to ultimately be more likely to develop cancer. And that's been used to a great degree in terms of predicting cancer risk on an epidemiological perspective. And then finally, I think we also understand that there is an increasing relationship between the gut microbiome and the human genome, and understanding how to characterize the gut microbiome is really being played up in the field of GI cancer, but also other cancers. So NGS technology has really been important in understanding how to characterize the microbial communities that live in our human ecosystem, and how that sort of interacts with the human body to promote or prevent cancer.
Thanks, Andy. So I want to come back to something that you said, Bill, which is the relationship between the therapeutics and the diagnostics. And we're seeing a lot of changes in so-called companion diagnostics. Where do you see that aspect going to guide therapy at an earlier stage?
Yeah, and I think it's essential for reasons we've heard already during the day. You want to make sure that the patients who are most likely to benefit from your therapeutic are the ones who you actually sell the drug to, get the drug to. Because remember, the side effects sort of are fair game for all, but the benefits are only for those where there's reason to suspect that the underlying biology will lead to a therapeutic benefit. So I think in terms of selecting and individualizing therapy, absolutely essential, but also in monitoring disease progression. When a patient is being treated, things are changing, and again, it's shown here at the MGH and other places in non-small cell lung cancer, that even in patients who seem to be doing well, they're beginning to show, using circulating tumor DNA or circulating tumor cells, the appearance of a drug-resistant mutation like the T790M mutation. And it's very important to know that sooner rather than later. And when we really think ahead, if these are going to be the first way the tumor gets around your treatments, then you might be able to say, this is a better combination or a better drug that we could develop next. So it's not just selecting the patient who will most benefit up front, but also guiding how we can develop better therapies, either new therapies or combination therapies in the future.
We're focusing mostly, as one tends to do, on the molecular side of things, because it's so precise and there's so much activity around directing therapy on the basis of knowing the target. But I'd point out, from the point of view of early detection and prevention, some of the most exciting work has been going on for decades in the area of imaging. The one that I would point to in my own field of pap smears, 70 years of using a rather simple image to guide patient care in a really powerful way. And we have now coming on board, even if you look at something as simple as pap smears, the ability to capture images in a digital manner and to use computational programs to do the analytics. So if you look at the way most pap smears are done now across the United States, they're done in automated systems that use computational approaches to look at digital images. That's a very exciting area for cancer diagnosis in general. I don't know, Krishna, given your role in Philips, do you want to comment on that and where you see that field going?
Yeah, if you'll allow me, I mean, there are two aspects to that. One is, of course, with pap smears and the role it has actually played in significantly bringing cervical cancer down from a top 3 to number 13 in the list of cancers. And if I can broaden the conversation to just looking at the role that digitization now allows you to play in general, take the field of pathology, for example. We're one of the big challenges that we're dealing with, and I'm wary of the fact that I'm speaking amidst two leading pathologists in the field, is really the huge challenge of inter-observer variability that exists, right? Somebody, when I was getting initiated in the field, somebody actually mentioned to me that Gleason was offered the same tissue thrice and came up with 3 different gradings of the tumor. But really, it is a problem that we see as we travel across the world. it's not just a intra-center problem, but it's also a inter-cancer center problem across the world. We feel that with compute resources, I mean, if you think about it, the pathologist is really eyeballing a piece of tissue and using this reference library really to be able to observe patterns in the tumor tissue, to then be able to grade the tumor, which then determines the fate of the patient downstream, right? Today, with compute resources, we can both take an algorithm-based approach to tumor segmentation, tissue segmentation, and grading. Very elementary things like a mitotic count, a Ki-67 score, is actually much easier done and more accurately done with compute resources than you can with with eyeballing tissue and using this reference library. So we're seeing the emergence of both algorithm-based approaches and deep learning-based approaches in really advancing computational pathology, which we really feel will both help to democratize pathology, in a sense, from the Socrates method that it's practiced today to really having the same standards of care across the world. But also we see the huge benefit of bringing down inter-observer variability, which translates to much better outcomes.
But I can see how this fits very, very nicely, because in addition to obtaining that tissue for a pap smear, it'll also be very, very possible, it is possible, to now do HPV genotyping on the tissue. And we and other companies perhaps are developing HPV therapeutic vaccines. So if you have someone with high-grade dysplasia or carcinoma in situ, and you know what their HPV status is, and you have the proper vaccine, you might be able to eradicate the vaccine from a patient at very high risk, which is where you'd like to put your interception or prevention drugs any which way.
Yeah. A good example of where early detection leads eventually to prevention. So one of the other areas where a better look at things, whether it's radiological or pathological, another area where a better look at things has really changed the way we detect lesions at an earlier stage and then treat them comes through Andy's field of gastroenterology, where scoping both from above and below has really changed our ability to detect cancers, particularly with colonoscopy from below. But even when you look at GI endoscopy at the present time, there are major changes going on, or major technology developments, both from the upper GI perspective, and the one we had thought about was something being developed a lot at Mass General, which is optical coherence tomography. And then from below, some of the detection methods, either by imaging or from fecal DNA. So Andy, do you want to comment either from above or below?
So obviously endoscopy has really transformed certainly colon cancer screening. I think we obviously have made a lot of strides in reducing colon cancer incidence through colonoscopy screening. And we've reached the point now where we're really trying to better provide that modality of screening to the general population. I think that's sort of where we're at now. So I think with respect to endoscopy and colon cancer, it's a very mature field, and I think we're really trying to kind of develop best practices in terms of how to optimize its delivery to the population. So increasingly now we're really trying to understand, how do we make colonoscopies more effective in terms of prevention? How do we make sure patients, in general get screened? And then we can sort of think about further iterations of colonoscopy screening in more difficult populations. In particular, there's a lot of difficulty still in screening patients, for example, with inflammatory bowel disease who have very high incidences of colon cancer. How to most appropriately screen those patients is a challenge. And so there's an increasing effort in trying to develop better endoscopic methods for that patient population. Similarly, I think there's really been advances in trying to improve our ability to detect and diagnose premalignant lesions that seem to be a little bit more worrisome. For example, serrated polyps or serrated adenomas are a subtype of polyps which seem to be more likely to lead to cancers that evade colonoscopic screening. So there is a lot of effort now in trying to improve endoscopy to detect these lesions, which are very difficult to detect on standard colonoscopy screening. But I think there's a lot of work also being done in upper tract screening. So certainly esophageal cancer is an increasing problem in the United States. Esophageal cancer deaths continue to rise, even though colon cancer deaths are declining. But our ability to really detect esophageal cancer at an early stage is really very, very limited. At this point, the only known premalignant lesion for esophageal cancer is Barrett's esophagus. The problem with Barrett's esophagus is that it's a very, very common lesion. So a large proportion of the population have Barrett's esophagus, but only a very small percentage of people with Barrett's end up developing esophageal cancer. It's estimated that about 0.5% of individuals with Barrett's will develop cancer in a given year. So if you have a very large denominator of patients with Barrett's esophagus, how do you sort of manage these patients? And so there's a lot of attention now being paid to trying to further risk stratify Barrett's patients into patients that are more likely to develop esophageal cancer. And that's by trying to determine if these patients actually have evidence for either low-grade or high-grade dysplasia in their Barrett's esophagus. At this point in time, the standard approach is random biopsy. So essentially, endoscopists will go down with a scope and just take random biopsies throughout the esophagus, hoping that they'll come across an area that may or may not have dysplasia. As you can imagine, that's very cumbersome, very resource intensive, and also relies on serendipity, just relies on the endoscopist happening to sample an area which might have dysplasia. So it's really an imperfect technology and an imperfect application of endoscopy. So there's a lot of attention now being paid to novel methods to better characterize Barrett's and better characterize those patients that may have dysplasia or high-grade dysplasia. So one of the areas that's been of intense interest is optical coherence tomography, which is a technology where you can more precisely look at a subcellular level what's actually happening in the esophageal tissue to understand if there are areas that look more likely to be dysplastic. In addition, there's an interesting set of technologies which are sort of merging molecular diagnostics with endoscopy. So one of the areas that we're also interested in at the MGH is a molecular imaging probe, which is designed to actually target areas in the esophagus which have overexpression of certain enzymes, which actually are overexpressed in dysplasia in Barrett's esophagus. And those enzymes specifically can be targeted with a molecular probe that when it sees those areas of dysplasia can actually cause a release of a fluorophore that can be then detected through an infrared endoscope. And so we're launching a clinical trial just in the next few months to actually examine whether that approach will actually improve our ability to diagnose dysplasia in Barrett. So there's a lot to be done within the field of endoscopy. And just to touch very briefly on the colon again, with respect to stool DNA, as many of you know, there is now this FDA-approved and CMS reimbursed modality of screening, which is to detect levels of fecal DNA in the stool, which are felt to indicate either cancer or polyps. And that's a potentially important new adjunct to what we have for colon cancer screening, in that we can, in a more non-invasive way, potentially determine whether someone has advanced polyp or cancer. I think the sensitivity and test performances are not up to par yet with endoscopy, but for those patients for whom they don't want to have a colonoscopy or would rather not have an invasive test, I think that does represent a potentially viable option.
Thanks, Andy. When one does NGS or when one does optical coherence tomography, you generate a huge amount of data on individual patients, and you can imagine the amount of data generated across a system doing many of these tests. But in addition to these novel technologies generating data, we are sitting in a healthcare system, in healthcare systems, on top of huge amounts of data. When we looked recently in the Partners healthcare system at 5 years of data in order to do our Epic conversion, we saw that just in the laboratory medicine systems between the two large academic medical centers and the smaller community hospitals, we were sitting on 500 million data points in laboratory values just across those hospitals for 5 years. And the radiology databases are also huge. So there's a tremendous amount of data sitting in these systems, and that amount of data is going to go up markedly. And so another area of great interest for diagnostics, potentially early detection, is a large data analysis, big data, data science, whatever terminology one wants to use. And there's a lot of excitement about the ability to detect diseases earlier on the basis of doing analytics on these large data sets. The example I would give from our own department is in the area of benign hematology, of anemias, in which one of the investigators in our department, John Higgins, is interested in red blood cells and took the standard information, all of the measurements coming out of routine CBCs, complete blood counts that all of us get when we go in for our annual checkups. What he did was he modeled normal patients' red blood cells across the 120-day lifespan in large populations of red blood cells and created a mathematical model based on this cheap data that's already sitting in the system. And then he plugged in diseases such as common anemias, iron deficiency anemia. And what he found was that he could actually detect patients who would go on to get iron deficiency anemia 2 to 3 months in advance of what the current diagnostic criteria are. Now, the interesting thing there is that's not using any new expensive technology, that's using existing data within the system. And by doing novel analytics through mathematical modeling, one can develop early diagnostics and essentially treat a disease before it has developed clinically. That's a very exciting area, and so I'd ask the panelists if any of them want to comment on the potential of large data sets for contributing to earlier diagnostics. Max?
So I would bring up the possibility that we have now to interrogate formalin-fixed paraffin-embedded tissue and therefore interrogate retrospective databases with long-term follow-up, particularly in prostate cancer or breast cancer or GI as well. And looking at normal tissues and looking at biomarkers that have been proven in cancer to be predictive of aggressive or indolent disease, but looking in the normal tissue to see which patients can be predicted to develop cancer. And there have been studies now in breast cancer and in our own laboratory in prostate cancer where we find that either tumor cells or even the surrounding stromal cells in the microenvironment are actually predictive of behavior of tumors. And utilizing either computational techniques as were described before, or multiplexing of either RNA in situ hybridization or immunohistochemistry, this is becoming now a reality. And we will be able in the future, I think, to predict which patients are more at risk of developing cancer or not utilizing normal tissue. But we need to use retrospective databases with long-term follow-up to do that. And the pairing between pathology and epidemiology, which we've been working on for several years with the Harvard School of Public Health, has been of extreme interest to us and yielding very important results, which is something you're doing as well.
Yeah, I know. I mean, speaking from the standpoint of epidemiology, I think it's really amazing how much data is really out there, and it's almost a treasure trove in terms of the potential to use that data to really help us understand how we understand these diseases better, how to understand cancer on a more fundamental level, but also to really help us in terms of understanding more specifically what sort of patient populations are of particular interest in terms of prevention. I think being able to bring all that data to bear is going to be an important step for the field. And I think that applies to not just molecular data and pathologic data and biomarker data, but also just clinical data and clinical information. Just the amount of clinical information in these data systems will be enormously important for us to mine in the future.
And it also draws attention to the really huge emerging need in biomedical research, but also eventually in clinical care for information scientists, data scientists. The need is it's really hard to meet the need at the present time. Finding those people, creating a pipeline to train those people is really very important right now.
We're actually beginning to see two very interesting approaches for actually getting to the same answers. We're seeing a top-down approach as well as a bottom-up approach really for deciphering really what the root cause of the disease is. The top-down approach is what IBM is taking with Watson, for example, or Flatiron is trying to take, which is organizing all the data from EMR and all other sources to really create an oncology-specific EMR, potentially to be able to build analytics to be able to guide first line and second line of therapy. And you're also seeing a bottom-up approach, which is more targeted, which is leveraging the data that comes through from imaging, from pathology and molecular data to really look at are there patterns that you can observe? Almost can you tunnel down from what a PET CT scanner is able to tell you down to the molecular level and tunnel back up to get that one view of the patient. So there are very interesting approaches, but as you said, if we really want to leverage data, we don't have the infrastructure ready, given the volumes of data that needs to be crunched through.
Could be slightly different, you never know. So we envision a time, not sure exactly when it'll be, when we're much more like our cars. So our cars have hundreds of sensors monitoring every critical piece of the machinery, the engines, the transmission, the electrical system, the brakes. And before anything actually goes wrong, there are signals that are occurring and your check engine light goes on. And it's so annoying. You have to bring your car in, and what you do then is you plug it into a computer which downloads all the information from the sensors and gives you a diagnosis and tells you what to do. Well, personally, I don't think it'll be that long until we're covered with sensors or embedded with sensors that are constantly monitoring us. And at some point, our check engine light will go on. I don't know if it'll be on our forehead or on our cell phone or something. And we'll get taken into somewhere. And all this information from our sensors will be downloaded into an IBM Watson-like contraption that will say, and by the way, your blood pressure is too high, or you're on your way to getting a polyp and take another aspirin, or something along those lines. So the providers of the futures may look a little bit more like the mechanic of today. You never know, right?
Yeah, I agree. The area of wearable devices is going to be a tremendous one. We're already seeing it start to have inroads in some of the neuropsychiatric diseases, picking up alterations in skin. And again, it really promises to do pretty big things. But as you point out, really raises the huge data issue as well.
Huge. How you handle it. It's incredible.
So we have about 5 or 6 or 7 minutes left. Maybe we can look even further to the future now, look sort of 10 to 15 years down the road. We've touched upon a little about early detection of viruses or other diseases that might predispose to cancer and treating those. We've talked a little about genetic predisposition and environmental causes. We've talked about potentially the ability to see abnormalities in normal tissue that might antedate tumors developing. When you start thinking about the future, what gets each of you excited about it? Where do you think the exciting breakthroughs will be on the sort of 10-year horizon?
I think that the integration of all these data is going to be very important to get us to a new place. The integration of clinical data, the integration of traditional pathologic data, and the integration of various omics that will give us a systems biology type approach in predicting how a tissue within an organism will behave. And we will probably be able to do that from normal tissue or from early lesions in the future. But the complexity of the whole thing is the integration of all these aspects and the amount of data that needs to be analyzed. And right now, at least in pathology departments, we're not yet able to do that, and we have to train people to be able to assess data that way. I think it's a very exciting time. Technology is rapidly evolving, and we're trying to keep up with it.
Krishna?
We spend a lot of our time really looking at where will the disease and diagnostics really be 10 to 15 years down the road, and where will therapy be 15 years down the road, right? Our view of the world, if I start with the therapy first, and that will actually dictate what happens to diagnostics as well. Our view of the world, if I take it down to the basics, is really that we see targeted therapies accounting for about 80 to 85% of dollars spent on cancer therapy. It's already at about 70%, and surgery and radiation therapy really will shrink in terms of total dollars spent. That's kind of the first important view of the world that we see in about 15 years from now. The second important area of focus is that if we sift through all of pharma's R&D pipelines, it seems to me that really the three big areas that targeted therapies are working on are of course, in targeting active gene mutations, in using the microimmune environment to actually stop the tumor in its tracks, and also in, if you will, stopping the signal transduction pathways between cells. If this is true, then we see the role of the medical oncologist becoming primary in therapy, and they're actually driving, some of which is already happening at MGH and several other places. But if you look across the world, diagnosis is actually in silos today. You have radiologists who can't read a pathology report, and you have pathologists who don't necessarily understand the molecular world, if I may say so. And we see really with the primary role of the medical oncologist, really we see a convergence really happening in the next 10 to 15 years across the world between these fields, particularly pathology and molecular pathology. We see a world where liquid biopsies will play certainly a very important role in therapy effectiveness monitoring. We do not see it replacing tissue biopsy till we have more evidence and data. And really, to Massimo's point, I guess all of this will require the diagnostics of cancer to be way more quantitative than it is today. Today it's still an art form.
What really excites me, David, is the idea that we'll shift our attention away or toward prevention. And I practiced medical oncology for almost 30 years. Never had a patient walk in and say, Dr. Hite, I'm so happy that I was diagnosed with cancer so you could treat me. Never heard that once. They always want to know, how could this have been prevented? And number two is, can I be cured? And in the pharmaceutical industry, with some exceptions, we focus on the manifestations of disease and treating those, but we don't focus on curing diseases, because you heard earlier, those require new levels of collaboration between companies. And we don't focus on prevention, with the exception of infectious diseases. So to shift that focus and get more attention onto these very early manifestations and then intervening before a disease ever happens, to me, that's what really makes me excited.
I think also what's very exciting is I think we're really moving into this concept of precision prevention. I think in the way that we've really made advances in terms of being able to more precisely deliver therapy in a targeted way, I think we're really going to see the prevention field gradually move to this concept of being able to deliver preventative interventions in a more specific and targeted way. And I think that has particular application when you think about using pharmacological agents for prevention. And I think when we start thinking about drugs like aspirin, metformin, multivitamins, or specific types of supplements, probiotics, I think these are all very exciting potential population-wide interventions that could make a difference in terms of cancer incidence. But ultimately, I think the more effective approach will be trying to figure out who specifically may stand to benefit the most from these interventions, and that has to do with both their likelihood of developing cancer, but also their likelihood of developing potentially side effects from some of these agents. So I think this idea of precision prevention will be a very important concept going forward.
Thank you. So I'll just conclude by pointing to one important topic that we haven't touched on, but that cuts across almost everything that's been discussed. We've discussed the advent of new powerful technologies, new powerful analytics based on the data coming out of those technologies. But all of this is dependent on proper patient education. And so in order for the stool DNA sample or approach to work, or the optical coherence tomography, there has to be a major public health effort to educate patients about the opportunities here to get at the issue that Bill was alluding to in his last comments about prevention. How do we educate people to inform them about these new technologies in order to get them into screening programs for the long-term goal of prevention? I'll end there, but I want to first thank all of the panelists. It's been great having this discussion. Thank you very much for lending your expertise.
Thank you.